So last 2 years I've been involved with the contouring section part of this meeting, and we had Erin Gillespie that you see here in the middle from Memorial Sloan Kettering give a talk on eContouring, a website that she's developed. And when we were planning the meeting for this year, we quickly realized that this should be the centerpiece of the contouring session this year. So we've Dr. Finkelstein has called her the director of contouring for the meeting, and she brought in 2 other helpers, Jim Murphy and Jill Gunther. Jim's from UCSD and Jill's from MD Anderson. The only thing I want to add before turning this over is that this is a phenomenal project, and I believe this was started with some ACRO seed grant money. So it's nice to see the productivity of the seed grants. Take it over.
All right, well, thank you for that introduction. Of course, we want to thank the ACRO committee for inviting us. So as Dr. Lally was mentioning, this session is really going to be focused a bit around eContour.org, which is a website that, as our disclosure, Jim Murphy and I co-founded at UCSD in 2016. So today we're going to basically showcase a product, a tool that's being built into the website for web-based contouring. So for those of you that did bring your laptops, we're inviting you to join. Now, this website is currently a reference for a tool for guidelines that you can access. It is free. It requires login just for purposes of tracking use for research purposes and education purposes. But for today, you won't have, there's no requirement for login. So when you go to the website page that will show you, you can just use it. So a quick outline for the session. We're going to start with a brief overview of the clinical impact of contouring, show a little bit of results from last year's survey for those of you who were here and took it, and then some a brief updates, and then we'll get into the kind of live contouring, looking at these 3 disease sites. And at the end, a survey for you. So I think as radiation oncologists, we all appreciate that contouring is really a central part of what we do every day. We see patients, we evaluate both their clinical and their social needs and understanding what the best course of treatment for them is, but a lot of what comes down to is what we actually target and what we treat, how we avoid normal organs. But my question initially was, what kind of data do we have to actually prove that we're impacting outcomes? So there's actually been a real interest in looking at QA on clinical trials, and we know that protocol deviations do impact survival. And there was a meta-analysis a couple years ago actually looking at 8 different trials in head and neck, GI, lung, and peds that really showed that protocol compliance improved overall survival and reduced treatment failure. To kind of showcase the role of contouring specifically, one of these trials, the TROG-0202 trial, actually, may not remember it because they were testing terpazamine and it was a negative trial, but they actually did a really good job of prospectively defining protocol deviations and then looking at them, and they found that for the patients that had deviations, their overall survival was actually 20% worse. And when they looked at the cause of the deviations, contouring comprised 25%, or at least incorrect target definition, essentially. And then they also looked at the deviations that were based on, they were actually seen more commonly in centers that enrolled fewer patients. So there tends to be a correlation, and we've seen this in multiple studies now, including using big data, that the more often you do something, the easier it is to kind of follow the instructions or give guideline concordant care. And so the question is, so obviously we need to be able to target the right thing to really maximize the utility of radiation. But this really gets at this idea of the amount of information that we have and to guide our treatments is expanding. Richard Zane presented a keynote at ASTRO this year, actually kind of mentioned this data on the left about medical knowledge and how it's rapidly increasing, and that in 1980, we thought that medical knowledge seemed to be doubling every 7 years, and by 2020, they're estimating that it could double within a few months. So I quickly looked at just how does this actually impact consensus guidelines? So in contouring, in the early 2000s, we started using contouring, and we started seeing the publication of these consensus contouring guidelines in the literature. And if you actually look at the rate of increase in the actual amount of guidelines that are guiding how we could contour, that is also increasing exponentially. And so there's a sense of information overload. And so that was at least a hypothesis that I had. And last year we tested that. We actually surveyed all participants, and we found that 73% of people had been in practice for at least 10 years, and that 85% were treating all disease sites. So we then asked, what resources do you most commonly use? And the RTOG atlases, the visual atlases were the most common, which was not surprising, kind of just reminding us that the visual image-based atlases are the most useful for contouring. And then we actually just tested, there were 7 guidelines that have been published either in the red journal or the green journal, and people actually responded correctly to about 42%. So it means that there are guidelines, there's information out there that we're not aware of. And when we asked about the barriers to actually using the guidelines, the number one thing was just not even knowing that they were necessarily published, and keeping up with the literature is challenging. The positive thing that came out was that we asked other things about guideline use, and the fact that they were not evidence-based, or that users may not be engaged in the development, did not seem to be an important component. But they did endorse the fact that sometimes there's not enough time, and that maybe the resources aren't comprehensive, which was sort of what we hypothesized. So I don't want you to feel bad about this idea that there's so much information, because at Memorial we've actually been piloting at the Watson for Oncology, which some of you may know is an IBM project that they're partnering with us to basically take all patient clinical data and then look and let the computer's deep learning algorithm understand the patient data and outcomes, and also do a complete literature review to come up with, well, what are the papers that should actually guide treatment? And they basically, like IBM, we had to change the project because they said that this is way too complicated. Our deep learning modules are really bad, and we've converted to actually just a clinical pathway where they got a bunch of experts in the room, and they said, well, if going through cases, like how do you decide one thing or another? And so, if IBM's Watson, which can win Jeopardy, can't figure out medicine, at least not today, then for you guys to be able to put know all of the available data that's out there is obviously a tall order. So our goal with eContour was to bring these guidelines into a way that you could kind of use it in your clinical practice. And this is a quick we did a survey of dosimetrists asking them which guidelines they used, and to contour head and neck OARs, and only 5% of them endorsed knowing about this multi-cooperative group publication. And so then we just contacted the author, and she sent us the DICOMs, and we have put those images and contours into our website. And so this is actually update. So last year we presented in February. Oh, bummer. So, and the head and neck OAR is now our #1 most frequently accessed case. And so these are the number of case views on the website, with looking also breast and GI. So then, just briefly, I'll kind of skip over this. So the next direction is actually, so VIA Oncology is working on radiation-specific guidelines, and some centers have now been, or pathways, I should say, have been using these. And it's really the only product that's actually gotten into the space of pathways, where you basically enter in your patient's data, and it gives you a suggestion of what to treat. And they've, Dr. Berrywall's been in charge of this project, and they've looked at hypofractionation for breast, as well as regional nodal radiation. And they recently contacted us to incorporate our image-based guidelines into their product to kind of help providers get the right information at the right time for their patients. But meanwhile, we started, we also surveyed our users asking, because I was getting emails saying, like, could I contour within the website and just compare my contours to the experts? And so we then surveyed the users and asked, who would you use this? And we found that people very strongly said, yes, this would be a useful tool. So we started developing it, and Today, we're actually going to showcase for you the first time, kind of outside of our pilot testing, how this website will work. We'll use it to go through 3 cases, and I'll have Jim Murphy start us off.
All right, thank you, Aaron. I'd like to thank ACRO as well for the opportunity to present our work here. So the first case we're going to go over is a patient that has a T3N1 anal squamous cell carcinoma. And at this point, for those of you with laptops, I'm actually going to ask that you go to the website eContour.org/ACRO. That's actually where the contouring module is located. There shouldn't be a need to log in, so you should just be able to go to the website. We can actually go through these cases one by one. So, sorry about that. So within the module, you should see a website that looks something like this, and go ahead and click on the first case, anal cancer. And I'm actually going to go ahead and just walk you through the individual tools within the contouring module. And before I actually go further, let's see if this will load. There we go. Okay, so this is the eContouring contouring module, and you can see here we have a pelvic CT scan. We have a couple of just basic image manipulation functions, so you can scroll up and down through the CT. There's also a bar up here that you can drag back and forth. If you want to zoom in, there's zoom out, so if you want to get a little bit closer, you can. With this image and a couple of other images, they're actually fused studies, and so if you go over here, there's a select overlay button. You can go down and select a PET CT scan. This will take a second to load up. We have a series of jokes to use if this really takes a long time, so hopefully this won't take too long. Still loading.
In terms of the browser, the best browser to use is Firefox, if you happen to have that. Otherwise, Google Chrome or Internet Explorer.
So much just to be a little bit of patience here in terms of loading up the images and also the fused images. You can see here, this is actually the PET which we have loaded up. You can again scroll back and forth and see the images for this patient. With respect to actually drawing, we have a couple of drawing tools up here. We have a pencil, we have a brush, and we have 3 target structures that we're going to ask you to contour. A GTV of the primary tumor, a CTV of the primary tumor, and then also your elective lymph nodes, focusing mostly on the inguinal nodes. And so just to kind of walk you through how this would work, if you wanted to go ahead and choose this structure, you can click anywhere here. This little checkbox will come up. And here you can select the brush. And it's just like most treatment planning systems. So you should be able to, and I'm sorry, if you actually try to contour on the wrong slice, we're actually only going to let you guys contour on one slice. You're not going to have to contour the whole case here. So you can actually click on the drawable slice. That'll actually bring you to this one CT slice that actually says drawable slice. And you can try to draw here. So if you thought this was a tumor, you can make it bigger. We also have an eraser that works, again, just like a regular treatment planning system. You can erase your structure. And we also have a pencil here, so you can actually draw just like you would in a normal treatment planning system. We have instructions on the side here if you need any help with that. And for the next couple of minutes, actually Jill and Aaron are going to walk around and see if they can troubleshoot individual people. Kartik, our programmer, is also going to walk around to see if he can actually troubleshoot any individual issues as well. When you are done with your contours, go ahead and please hit this green button. That'll actually submit your contours to us, and then we'll actually be able to review everybody's contours in real time. Don't worry, all these contours are completely anonymized, so we don't know who's actually drawing them. It's not like your face is going to come up. Here are your contours. It's nothing like that. So, but yes, go ahead and next couple of minutes we'll let you guys contour. And here we have some instructions up here as well with the website. So users with Chrome are having better luck than Firefox right now? Okay. I suspect we may have flooded the bandwidth here. Just would be a little bit patient. Any luck? Or? Okay, we'll give everybody a few more minutes. I do apologize. I think we have completely flooded the bandwidth here. Okay, that's submitted. Okay, good. Okay. So if you are able to get through the case and actually hit submit, you can it'll actually pull up the quote unquote gold standard contour so you can compare your contours to a set of expert contours. Okay. Sure. Okay, we can have people load up the case really early next time. Just get ready for the next case so we're not all hitting the button at the same time. Okay. 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 All right. All right, guys, so we're actually going to go ahead and just continue with the session. I do apologize if you had some difficulty loading up the scan. I know a few people have actually submitted. So we have a couple of slides on just teaching about anal cancer, and then we'll actually go over some of the contours that everybody submitted. So just real briefly, I think we all know that anal cancer is a very important disease. It's not a very common disease, though the incidence is increasing. Unlike a lot of other diseases we treat, especially in the GI world, radiation is curative. Patients are not cured by chemotherapy. They're not cured by surgery. And so this is a disease that we really need to be good radiation oncologists with. And I think a lot of times people get confused maybe or just say it's the same thing as rectal cancer. This is very different than rectal cancer. So in terms of how we treat these patients, a PET scan is a very important part of both staging and treatment planning. And so with the PET, there's been data that shows that this increases detection of involved lymph nodes, and in around 13% of patients actually results in a change of either the radiation fields or the radiation dose. So by way of treatment, I'm not going to belabor this. We all know that the standard of care for anal cancer really hasn't changed much in the last 45 years now. It's still standard 5-FU with mitomycin C is the backbone that we mostly treat with. Now cisplatin and 5-FU is an option in certain settings. However, really 5-FU and mito is still the standard of care. And also IMRT is a standard of care. RTOG 0529, as we all know, is a phase 2 study that evaluated IMRT in anal cancer. There are 2 important findings from this study. Number 1, IMRT reduced toxicity compared to historic controls. And number 2, 81% of plans actually had contouring deviations. And so anal cancer contouring is not easy. It's very easy to get tripped up with some of the details. And so here we have a slide that I'm not going to go over, but there were errors in contouring most of the organs that were actually involved, including the gross tumor, elective nodes, as well as normal structures. So patient setup, with this type of patient, we're going to do a standard CT simulation. And again, if you have a PET CT, we're going to incorporate that into treatment planning. Patient positioning, truthfully, the most important thing is that this is reproducible. Now, certain people are very passionate about supine versus prone. There's not a right answer here. Whatever you can do that's reproducible is probably the best way to go. And then finally, if you have the opportunity to use daily image guidance, this is a good patient to do because you can have issues with pelvic tilt and pelvic positioning that it's good to make sure you're setting up the patient standard each day. So the primary tumor, this is something that you're going to identify from the PET, from a CT scan, and also from physical exam. The CTV off the primary tumor is usually going to be around a 2 to 2.5 centimeter expansion off the GTV, though it's important that you trim this volume off of certain structures, including bone, uninvolved organs, such as the prostate, the vagina, as well as the ischioanal fossa. And so now we'll actually go, and I'll actually pull up some of the contours. We'll try to, at least. All right, we'll give that a minute to load up. Well, there it is, actually loading. Okay, so this is actually okay, so we actually have contours. So some of you were actually able to submit contours. So what we have here, all of these red lines are actually your contours. And so people actually were able to identify the GTV, which is good because you can actually see this on PET. I'm actually not going to pull the PET in here because I don't want to crash the system. Right now we're on a roll. But the gold standard contour that used the PET is this solid red line. So some people had smaller volumes, some people had bigger volumes, but we're all in the same ballpark. And so moving on, the high-risk CTV, go down here. Okay, so now there's definitely going to be a little bit more variability with this. So again, this kind of lighter blue, thicker line is the quote-unquote gold standard CTV, which is a little bit more conformal. We have a lot of people that are actually expanding their contours. So kind of going case by case here. Actually, the first person to actually submit, this is good. We're targeting the right thing, which is important. However, in this case, you could definitely trim this CTV back. And so right now, the CTV is actually going into bone. It's kind of going into muscle. That's going to be uninvolved, the pelvic floor. And it's also kind of going into this ischioanal fossa, which is an area that, unless the tumor is actually going through the anal sphincter muscles, it's unlikely that you're going to get tumor in here. Now, this is very different than the mesorectum. So the ischioanal fossa is below the mesorectum. It's below the pelvic floor, and it's lateral to the anal canal and the anal sphincter muscles. And so this is an area that you can definitely trim off. And just looking at a couple of other contours, this one is actually probably a little bit too big. This is a little bit too conformal. Conventionally, we would actually include all of the anal sphincter muscles, whether they're involved or not, in that high-risk CTV. And so really this division between anal sphincter muscles and the ischioanal fossa is really where you want to kind of draw that dividing line. And so we can actually kind of scroll up and down through other slices. We can take a look at this CTV, how this is drawn. And so here, as we're getting higher up in the pelvis, now we're actually including the mesorectum in this target volume. And so this is a little bit different lower, we're a little bit more conformal. And so that's a little bit different. The mesorectum, if we remember, this is where lymph nodes live. This is where there's oftentimes microscopic tumor deposits with all anorectal diseases. And so this is something that we definitely want to cover in that high risk volume. That's a good question. So it's sometimes can be a little bit tricky to see on the CT scan, but here, down a little bit lower, this is actually the ischial fossa. When you go up, you can start to see these muscles kind of flare out right here. These are the pelvic floor muscles. And once you're up around here, this is where it is. If you have a sagittal CT scan, sometimes you can actually see the pelvic floor muscles kind of go down like this. If you have an MRI, you can actually see it a little bit more easily. It can be a little bit difficult to see, but it is where you kind of get these streaky pelvic floor muscles that kind of come across right there. That's the division between the ischial fossa and the mesorectum. It's a good question, though. So just real quick, back to the case. So again, the ischial fossa, this is an area that a lot of people oftentimes contour when you really don't have to contour. So again, you're hitting the target, which is important, but we're also putting a lot of dose in an area that we really don't have to. And it's not that you're gonna get a lot of toxicity by treating this area directly, it's more that we're just gonna pump more dose into the pelvis, which is indirectly gonna result in more dose to the gynecologic organs in females, to the penile bulb in males, and also to skin, which is gonna be a direct predictor of acute toxicity. So the next area, that we're going to focus on is the elective lymph nodes. So in anal cancer, the elective lymph nodes include perirectal lymph nodes, presacral lymph nodes, internal iliacs, external iliacs, the pelvic sidewall, and inguinal lymph nodes. And this is pretty much every lymph node group in the pelvis. And so we don't really spare much anything with respect to lymph nodes with anal cancer. And so going back to the case, see if we can get, actually do one thing real quick. So looking at the elective volumes and how everybody drew that. All right, so this is good. There is a lot of heterogeneity. So this, again, this kind of brighter green line is the gold standard, covering in this case, it'd probably be the femoral vessels at this level. It's good to go big with these volumes, and I see a lot of people are actually doing that. So if we go through individual cases, here, this is a good volume covering the vessels, going really medial, which is actually important. Good, these are actually really good. So people are actually doing quite good with these. Occasionally we'll get, somebody will have a much smaller volume, like this is probably a little bit too tight, and that, yes, we are covering the vessels, however, the lymphatics actually can live a centimeter, sometimes even 2 away from these vessels. So we have to be pretty generous with these groin contours. And so unlike down here, where we can be a little bit tighter around the primary tumor, here up in the groin, we need to go big. And so back to this point, so the inguinal lymph nodes go big. That's probably the key take-home point. And so in general, also, another point is that when we treat the perirectal lymph nodes, we end up treating the whole rectum. So this is different than prostate if we're treating the pelvis. And this is different than other sort of gynecologic malignancies where oftentimes we'll spare certain aspects. And so when we go back to the case, just going through in general, looking at the volumes. So here we're just going to scroll through quickly and look at all the elective nodal volumes. And so we're covering all these nodal volumes. We're covering the rectum all the way up until it starts to dive into the pelvis where it becomes a sigmoid. That can be sometimes a little bit difficult to tease out exactly where it is. That'd be the peritoneal reflection where technically the rectum turns into the sigmoid, which oftentimes you can't see on a CT scan. However, when the rectum dives anteriorly, that's usually a good sign that you're out of kind of that high risk zone. And then in terms of how far superior to go, probably a good rule of thumb is probably L5S1 is a good division. Sometimes people will look for the bifurcation of the common iliacs into the internal and external iliacs, but again, there's probably no true correct answer here. And so that's pretty much it with anal cancer. Again, just a few of the big take-home points. Get a PET if you can. Trim your primary CTV appropriately. Remember your elective nodal volumes, and we really don't spare much with those elective nodal volumes, and then go big in the groin. And with that, we actually have Jill, who's going to talk about the next case.
Hi, everyone. How's everyone doing with the browser issues? Does anyone have the people who were able to submit the anal case Can you get back and pull up the second case? We're going to give you a little bit of time to work on that, and hopefully everyone's had, their computers have had time to catch up. But basically, this case is an early unfavorable Hodgkin lymphoma case, and just so we know kind of where we're starting, can I see a show of hands for anyone who would say that they kind of regularly treat lymphoma, Hodgkin lymphoma? Anyone? A few, okay. So this is, as I said, about a 40-ish-year-old woman with early unfavorable Hodgkin lymphoma. She has disease in the cervical neck, the bilateral supraclave, the left axilla, IMs, and mediastinum. And we have our one slice that we can draw on, which is kind of towards the superior extent of the mediastinum and including that neck. So if you can right now, try and pull that up and give me your CTV post-chemo. So this is kind of the treatment volume that you'd be drawing that you want treated after they've had chemotherapy and had a response. So we'll give you guys time to work on that. The case, there's only 3 cases, so let me take a look. So if anyone does have it up and working, remember that we do have the overlays. So for this case, obviously in lymphoma, PET's really important, and you do have that fused PET as an option, if you can also try and load that. I guess it is asking for additional information, but it's pretty important in lymphoma. Yeah. $35. Do you want me to go ahead? Okay. Okay. Perfect. Let's see. Oh, I have to turn that. Yeah, okay. Okay, well, let's go ahead. First, I think we should just take a look at what we're working with. So what we have is our CT simulation images. We have our PET CT overlay, and then we also have our pre-chemo CT. And let me scroll here to give you an idea of what that looks like. So this is the pre-chemo CT, which obviously shows a large, bulky mediastinal mass. If we take a look at, again, the PET, we see those areas of disease which were PET avid. And I'm going to scroll up for you, showing the bilateral supraclav disease, the left cervical neck disease, up to the top and back down. So if you encounter a case like this, and hang on, come in. How do I get out of presenting? Oh, we're good, okay. So given the show of hands, I think that lymphoma is not something that a lot of you treat very commonly. So I think today what we can focus on is the learning points to take away so that if you do encounter a case like this, and actually I'd just like you to think that if you do run into a case like this, how can you use eContour to kind of refresh in your mind, what are those important contouring aspects for a lymphoma case? And so the first step before you actually even open the image set that you acquired at simulation is to kind of go back and search and see what information you have to inform the contouring that you're going to do. So typically these patients are sent to us after they've had their chemotherapy. It's actually a real treat if you see the patient up front and are able to kind of do some planning beforehand and examine them. And so the first thing to do is to take a look, what is the initial upfront imaging that you have? Now, hopefully you do have an initial PET CT. I think that most medical oncologists do order those. Sometimes those are contrasted, sometimes not, and oftentimes you will also have a diagnostic CT set that does give you that contrasted information. If a patient has more than 2 cycles of chemotherapy, they're often getting a mid-chemo PET, a PET after 2 cycles. And oftentimes patients do respond really well, and you'll see a full response to chemotherapy after just those 2 cycles, but sometimes that's not the case. And even if the patient's coming to you after 4 cycles with a full response, make sure you do look back if they have that PET CT, because sometimes you'll find surprises, and that there's a little bit different disease distribution at that interim PET than even at the end. So don't disregard that information. The final PET CT is an imaging evaluation that sometimes we do have the luxury of ordering. If at your institution you don't routinely use contrast at your time of simulation, as we don't, we often do order that PET CT with contrast, which really helps to delineate the vessels from the residual CT mass. So all of those things are things that you should be taking into account and thinking about, again, before you even start contouring. The second thing to really seriously consider is your patient positioning. So there are a couple of different things that we consider when we're setting our patient up for simulation. So specifically, what areas of disease are involved? Is it just a neck? Is it neck and mediastinum? Is the axilla involved? And is this a female or a male patient? So for example, if we have patients with axillary disease and it's a male, we'll often put their arms up to try and elevate that axilla and then help us get a better lung DVH. But if that's a female, especially a young female, we might position them with arms down because we know that arms up would give us a bit more breast dose. And so you make those decisions to give you ultimately the best DVH, but then you're going to need to go back and see how all your diagnostic imaging was acquired, because there can be drastic differences when you're trying to contour depending on what your CT sim looks like compared to your diagnostic imaging. So if we take a look here at our eContour case, I guess thanks. We see that this CT scan was acquired in the arms down position, and our pre-chemo CT also is in the arms down position. But if we take a look, even though both of these images were acquired in the exact same arm positioning, we still see drastic differences in the anatomy, such that if you just contoured simply on the pre-chemo CT, you're going to be outside the body in some cases, and certainly outside your target area. So the other thing to really take a look at is the difference in arm positioning with where your lymph nodes sit. So you can see here, this is a patient who has CTs acquired in the arms down and arms up position, and you see how different that same lymph node, which is circled, is. I'm not in presenter mode again. I just need. Thanks, perfect. Okay, and you can see how different that lymph node positioning is relative to things like the sternum, the ribs, the carina. And so vessels are something that we really look at, but you have to be very, very careful that you're being generous enough, and that's one of the main teaching points for contouring lymphoma when you have all these variations in your imaging. So, the contouring guidelines that we have are set by the International Lymphoma Radiation Oncology Group, ILROG, and what is currently advocated for is something called involved site contouring. And so this is in contrast to the involved field radiation fields that were used in some of our big German Hodgkin's trials, like the HD 10 and 11. So it's a little bit tighter. And what it asks is that we take into consideration the superior and inferior extent of disease. So how high up did my cervical nodes go? How far down or inferior was I in the mediastinum? And we're covering that entire area, nearly always continuously, unless there are large separations in those nodal volumes, which is pretty uncommon for Hodgkin lymphoma, to be honest. But the thing that we do need to really pay attention to is that this disease is going to shrink after chemotherapy acts. And so that bulky mediastinal mass, which was pushing the lung, far displacing it, no longer needs to be covered completely. The mediastinum itself does, but we don't need to be out into the lung like we were. So with that, the probable, like I said, you guys were asked to contour that post-chemo CTV. There are a couple of other volumes that are talked about in the contouring guidelines, the pre-chemo GTV and then an ITV, but I think everyone's pretty familiar with those types of volumes from kind of other disease site contouring. So we're going to focus the most on this post-chemo CTV. So let's take a look at what everyone did. We have quite a few contours, so I think people were successful. That's great. Let's first look at our consensus contour or expert contour. And what you see here is that we have covered the entire mediastinum. We've omitted trachea and esophagus. Let me get rid of this overlay here so it's a little bit more clear. The entire mediastinum going down into the axilla. If I show you where the PET avid disease was initially, what you'll see is that we've included all of that site, thus the term involved site contouring. So even though we have these areas of PET avid disease which are slightly displaced and in different positioning because of the patient positioning, we've included that entire level, that lymph node space, that fatty space, and then again that entire mediastinal level. So now let's click through. I'll leave that on overlaid. and take a look at what everyone else did. So this participant looks like they pretty much contoured the PET avid disease, and there is something called involved nodal radiation therapy, which is a bit tighter than involved site. This is only advocated for if you do have that luxury of having seen the patient up front. So you can simulate them in the treatment position, and you have a much more of an apples-to-apples comparison, and you can be very certain of where those lymph nodes sat initially. You're not wondering kind of, well, where did they go after the chemotherapy? But this is probably, these contours are probably, they're too tight and for the CTV that we'd want to be contouring. This person looks like they're very keenly aware of the fact that Hodgkin lymphoma patients live a long time and we want to be as tight as possible. We want our volumes to be very small and very conservative. And so it looks like they're trying to avoid some of the vessels and normal structures, which is absolutely appropriate. It's probably a little bit tight, especially we definitely want to make sure that we're laterally covering that fat space, laterally, superior, inferiorly, where those lymph nodes were. And so I would definitely bring that contour back farther. This is a very generous contour. You probably don't need to be all the way out, in the bone and the skin. So I would take that off of those normal structures. And again, what I was talking about. So I bet that this probably matched the actual delineation of the bulky CT mass that was present up front. But this is shrunken back, and so that space doesn't need to be covered anymore. That's normal lung tissue. This one looks like it's chasing that fluid that was sitting in the bottom of the lung. And even if that pleural fluid was involved, this is combined modality therapy. Patients are getting chemotherapy, and we don't go chasing all the microscopic disease that was potentially in places outside of the target that we're trying to create. So again, this is over-treatment. And then this out here on the left side of the superclave, just because we are treating one superclave, we don't necessarily need to cover that other side. It is involved site contouring, so if there were nodes there, we cover them, but otherwise, those don't need to be covered. This one is close. We're omitting a little bit of the mediastinum, and the blush that's there on the PET is actually quite light on this overlay, and so that person probably didn't see it. We don't really feel comfortable usually omitting part of the mediastinum. We usually do include the whole thing. Some people might if they did. Again, we're following involved nodal contouring, but typically we do cover the entire mediastinum. This one's very close. Again, I would pull that contour out laterally. We'll click through the rest. Again, I would make sure that I cover those nodes that are in the superclave area, also very close. This one is similar to the one we already discussed, where this blush over here on the PET is difficult to see, but there. This one is almost spot on, and a lot of repeats there. So this is great. Let's go back and take a look at a few more slides to think about. So these are the common errors that we've already talked about many of. So as I said, we typically do contour the entire mediastinum if the mediastinum was involved at all at that level. Our volumes do day by day seem to get smaller and smaller as we're more keenly aware of toxicities and more confident in our outcomes. But as of right now, we do contour the entire mediastinum. And then we talked about including the entire fat space at the superior inferior level where those nodes were, and not contouring into the normal structures. So take this out of bone, take it out of the uninvolved soft tissue and lung tissue. Sometimes things that are tricky on PET, just because these are young, healthy patients, and we do see kind of some equivocal PET activity. And so things that come up a lot are, does the patient just have brown fat? Is it symmetric? Is it just muscular activity? Is there some type of biopsy site causing PET activity that you're uncertain if you need to cover? I do caution you that sometimes patients do have excisional biopsies and that then are not PET avid, and you do need to make sure that you are covering those areas. So ask a patient, where was their initial biopsy performed? And as always in PET CT, look for the CT correlates, right? If you're still uncertain, you can, of course, ask your radiologist their opinion. And then as radiation oncologists, we always are considering how much is this going to increase my field? Do I think it's going to increase toxicity? Yes or no? And kind of make your final decisions. So let's go through the rest of the images on our eContour case and remember what we mean by involved site contouring. So if I'm scrolling up into the neck, I start superiorly where I first see that PAT activity appear. And I'm including that entire nodal space, that fat space on the left. I'm coming down. I still have nodes here, so I'm including that. And you can see that we start including the other side, the right-sided neck, once the PET activity appears, and we have those involved nodes. Once those disappear, we can come off of that right side and then continue down in the mediastinum, covering the entire mediastinum with how the disease has regressed to cover the inferior extent of disease. So I'll scroll back up with more of an overlay, and hopefully you can still see it well. Carving out of vessels when they're clearly not involved, but again, we don't try and get too cute. I don't think you're going to be able to completely omit that.
Your internal memory curve, on the right side, is that just
Yeah, it's a little hard to see because with the exact, here, let's see if we can. On the overlay, it's a little bit light, but there's a blush there. It's certainly brighter on the other side. So those are the general approaches to contouring a lymphoma case. Let me see. And so your take-home points are just consider your patient positioning. You do need to be more generous if you have differences in arms up, arms down position, or even just different CT scans. Make sure that you're including the entire lymph node level and put on an appropriate PTV for how confident you are in your patient setup. We need to include all the lymph node regions that were present pre-chemotherapy, but we don't need to be covering areas that weren't involved. And also consider normal anatomic boundaries. Again, where the disease has regressed, please don't contour normal tissues after that chemotherapy response. So now Erin's going to come up and teach us about breast contouring.
Okay, so thank you all for sticking through it with some of the Wi-Fi issues that we've had. I'm glad to see that we had some submission of contours so we can discuss these. We'll take one more chance for like 5 minutes or so to kind of try loading up the breast case and see if we can get some contours submitted. Again, so you'll go to the ACRO, specific ACRO page here at eContour.org/ACRO. You'll select the breast case, and then we'll just have you contour each of the axillary levels on one slice. Again, and the preferred browser is Firefox, seems to be working the best. We'll come around again just for a few minutes. I want to get people a chance to, if you are able to load it, to try the contouring, but we won't take too long, and then we'll kind of go over some of the issues.
They might have already, a lot of people have already submitted through.
Do you want to get? Oh, there's really only one more person. Oh, so I should get going. Okay. So it seems like people are mostly submitted, so I think we'll get started here, maybe end a little early. So obviously, when we're talking about breast node contouring, I just wanted to bring it back to kind of the basics. So this picture is really sort of reminding us that obviously the lymph nodes we're treating the axillary lymph nodes because the drainage is really along this subclavian axillary vein. This image also kind of nicely reminds us of the location of the internal mammaries and sort of the vessels, the veins there that are also draining, particularly the medial breast. But we now have increasing evidence that we should potentially treat the internal mammaries for node-positive patients. This image also reminds us that the location of the brachial plexus, which is on the brachial artery. So these are obviously very close, but we think about the vein in terms of our nodal, but both vessels are essentially what are going to sort of guide us. And then this image is just going to kind of remind us of our basic vascular anatomy. We have the aortic arch, and then the carotid's going to be medial. The subclavian turns into the axillary vein as it goes under the clavicle, and then for the vessel on the left, we actually see the brachiocephalic, and then going up to the internal jugular and the subclavian. So if we come back to our case. All right, so we will start with the level 1. We'll zoom in here a bit for us. Yep. All right, so we got a lot of submissions, which is great. So essentially when we're looking when we're contouring the levels in the axilla, a lot of what I think can be confusing is that the guidelines often will actually delineate based on the anatomy. So just before we even get started on looking at these specific contours, let's remind ourselves of when we look at these, they'll talk about the subscapularis muscle, which is going to be this muscle back here. So posteriorly, we want to come to that muscle. Laterally, so the latissimus dorsi is actually the, where the surgeons, that's sort of the limit of their axillary dissection, which the level 1 is going to be the nodes that are removed in our axillary dissection, as well as some of level 2. And as we go through, and essentially, as we remember, in real life, actually, sometimes contouring will depend on its precise nodal level, so the pec minor being the, that's the major, being sort of our border on the level 1. So, and we obviously don't need to include muscle. We need to be a little bit more generous here because, really when we think about nodal contouring, it's when we look at these patterns of failure, it's the fat spaces that are going to sort of be where the nodes can even, usually it's sort of around the vessels, but keeping an eye on the fat space in the area. But, and then, it's interesting, this question of how laterally should you go, I've talked about this with our own surgeons because they sort of, when they see, we often want to cover that area because it's often in our tangents anyway, but they point out that really that's beyond the limit of a normal dissection. So I'm not sure that if you're using contouring, if that needs to specifically be included in your volume. All right, so we'll just switch over to the Oh, and then the other thing I wanted to mention, the upper and lower borders of level 1, technically the lower border is supposed to be in the insertion of the pec minor muscle, but on a CT that's hard to see, so technically the 4th rib or 5th rib is what RadComp will advises. And then superiorly, also somewhat controversial, really including where these vessels are crossing as, in your superior border. This can get dicey because the humeral head is here, and we, it's a little bit controversial, like, should you include the humeral head? Usually, when we're trying to treat the level 1, including a couple slices of the inferior humeral head is okay, but that is a judgment call. So on the level 2, we're obviously looking at the pec minor, and, this is, again, we now have multiple consensus guidelines from RadComp is slightly different than RTOG, which is slightly different than ESTRO. But there's definitely interpectoral potential nodes there. So including that area in your contour is advised. And then we'll kind of go through. Unpan. I'm not sure why I'm not. Do you know why I'm not going through here? What did I do? I have this.
You have it on there.
Oh, we'll reload it. Again, so level 2 is going to be the area that is also this sort of controversial, like, if you only have a sentinel node, level 2 can be excised on the axillary dissection, but not with a sentinel node. All right. All right, so here we have our contours. We'll zoom in. Technically, so again, we're on a slice where we're seeing our vessels crossing. Some people, in terms of, on this specific, we'll go through the contours first. Again, you don't need to include the pec major, but that would be included in your tangent field. And to some extent, this gets down to these definitions of level 1, 2, and 3, and honestly, when you're treating, you just need to make sure that you're including all of the levels. So people did this one quite well, which is not kind of what I expected, and I'm glad to see. There's a little bit more variability in the level 3, so these are going to be medial to your pec minor. As we go through them individually. Okay, so actually, I like this one. All right, so this is sort of an area that the original RTOG Atlas did not do this, but connecting your level 3 with your superclav volume is actually now recommended because this vessel is essentially what our target is and where we know our lymph nodes are. So if we turn on the subclavian and axillary vein, we can actually see that it comes in here. As we're going down, we see the brachiocephalic becoming the subclavian, and then it actually goes up into the neck with the internal jugular. So these are kind of what are guiding us here in this level 3. We'll also then go back to move into the superclav. And now we'll take a look at the superclav volumes. I'll see it again. What's up? Oh, that's also an issue. Okay, cool. All right, so this person contoured the level 3 as the superclav. So that's, honestly, the ESTRO guidelines no longer call it the superclav. They call it level 3 and level 4 axilla. And, so a little bit is nomenclature. Again, we got to make sure that we're including. So again, at this level, we want to include the vein as it sort of goes into the brachiocephalic and internal jugular. This contour is coming all the way to the trachea. Now, the RTOG Atlas specifies coming medially and not including the trachea or the thyroid in particular. The issue medially, and so here's our carotid artery, which all these things are actually contoured for us, and I'll show you at the end, the case that you can reference. So whether or not to include the carotid artery is also a little bit controversial, and the reason for this is that historically, we really, if you contour the carotid, you end up treating some of the esophagus and the trachea, and we just looked at our proton initial experience at Memorial, and a lot of these patients were treated on the RADCOMP trial, and 50% of patients actually had esophagitis, which we don't historically think of when we use 3D conformal fields. And so it's kind of an area of question, is like, should we actually be so generous on covering the carotid artery and cause esophagitis, or should we just be more lateral? And the ACRO guidelines do not, they specifically say cover the internal jugular but not the carotid, partly for that reason. And I've talked to certain other experts around the country, and they say the same, that, covering the carotid will increase that dose. And there is certainly both acute and there's potential the incidence is low, but there is lung cancer and esophageal cancer after breast cancer radiation. So, being aware of that. And again, I would be a little bit, certainly not come and include that area in your planning. Oh, we have people on both sides. Again, this one's sort of coming in front of it, so you're definitely going to end up treating some of that. You don't need to include the bone. Whether or not to include the muscle up is questionable, but just don't include the bone. And then the pleural edge is you should not include lung in your contour. All right. The other thing, so as we were treating more internal mammary nodes, by contouring the supraclav kind of down to the bottom of the clavicle, or where the first rib, we start to get into the internal mammaries. So connecting the supraclav and the internal mammaries is recommended now on RADCOMP and ASTRO. Yeah, we end up using partially wide tangents, honestly, more often than we use an electron match, and that's a good reason, particularly for your thicker patients. But, in making sure that you're covering that area is ideal, certainly. It's a good question. Okay, so let's go back to our slides really quick, make sure that okay, so again, this is what the, how do I go to presenter mode? Command return, right? Okay, so this is the ASTRO guidelines of what they look like. Again, ASTRO has decided that, we're really covering only that subclavian axillary artery and vein. Their supraclav volume is only 5 millimeters above and below the subclavian vein, and then they also connect to the IMNs, as we talked about. But so I think I'm presenting to you all the different consensus guidelines because there's differences, and breast can be really frustrating for that reason. And so thinking about what the fundamental issues are, and what kind of the minimal. So that's why I focus on the vein, where the lymph nodes are tracking, and then minimizing toxicity, but there are at least some of these concepts that are similar across the different guidelines. So the next question is the level 2 and 3. So in, whether or not to cover, how high to cover, essentially. ASTRO does not go, so the definition of that you'll see in some places is using the insertion of the pec minor, which inserts on the coracoid process, which to remind us is below the acromioclavicular joint, which in 3D conformal was a bit of, can be a margin or where the block edge goes. So on a cross-sectional, this is from the RADCOMP Atlas. It's showing you that the level 2 and 3 are actually going all the way up to the coracoid, and then again, this idea of connecting these volumes. this is for our anatomy reminder. This is a screenshot from an atlas that Memorial is putting together that really guides the use of IMRT in breast cancer. Nodal radiation, which is still somewhat of an area of investigation, really. As we do IMRT, we really have to be confident with our contours and understanding what areas are at risk. But this is sort of putting us up here at this level of the coracoid with this, again, and the volumes are sort of changing in shape and size because at the end of the day, the difference between level 1, 2, and 3 may not be as important as just covering the area. So then there's a question also about the posterior neck. So we were talking about the supraclav in our contours. Now the posterior, like how far back should we take the supraclav is, you can use, by definition, it's the scalene muscle, which is very close to the sternocleidomastoid muscle. So the question is like, what about all this space behind? And this is what we're calling the posterior neck. It was included on the RADCOMP trial as an optional volume. A lot of times with 3D conformal, just with an AP field, you won't necessarily cover it, but if you do a PAB, so it's still a question, an area of investigation, but the party line for most experts that have written and I've talked to about this would be to really only treat this area for high-risk patients. So if you have a patient with a positive, grossly positive node in an adjacent level, otherwise we don't know, but it may expose the patient to more, muscle stiffness in the posterior neck. And then you didn't contour this today, but the IMN, what we find is the most common site of recurrence is really up next to the sternum. So even though these vessels are slightly lateral, and some will say, put at least 5 millimeters on the vessels, which I think is wise. You should just also make sure that contour just sort of abuts the sternum. So to kind of summarize some of the key points, I think we can, talk about side effects. So there's, as being an important sort of endpoint, there was a ACRO abstract from John Strauss looking at actually in the setting of a patient that's gotten an axillary lymph node dissection, treating the level 1 and 2 intentionally can actually increase lymphedema, which I think we knew, but it was the first time he'd shown that. And so, but doing that only for patients with 4 or more positive nodes. There's some question of whether extracapsular extension alone after an axillary dissection is a reason to intentionally treat that area, and I think most people would say that's not enough evidence to expose the patient to extra risk. And then the AC joint we pointed to is essentially what we hypothesize is what's contributing to the shoulder stiffness. So making sure that while you may go up to the coracoid, you do not want to include, and on 3D conformal, you can actually block out the AC joint. Again, for the supraclav volume, I think it's, we definitely include the internal jugular vein, but whether or not you go all the way over to include the carotid you definitely want to avoid the trachea and the thyroid. Hypothyroidism actually is pretty rare because we're only treating one side. There's no reason to cause it. And then the esophagitis risk appears to be real, and we don't know if treating to cause esophagitis is worth the toxicity. Covering, again, the IMNs we just talked about, and then I didn't hit on this, but one of the most important things that we do in breast cancer, particularly with tangents, is to avoid the heart, either with an MLC block, ideally with DIBH or prone as well, positioning for left-sided patients. And then the last thing I will so you guys were working within our new sort of an ACRO page that we made, which has the active contouring. But if you go to the main site, and I mentioned this because I saw a number of you taking photos as we were going, and that's one of the reasons that I want to incorporate this website into actual education sessions, because I think while you're learning today, I just threw at you 50 different, anatomic areas like organs and vessels, and you may not remember all of that. So to be able to reference what we're talking about, so if you go to eContour.org, well, the homepage is just eContour.org, and then you go to cases. So you do have to log in at this point in our main site. Again, I said it's free. We just want to be able to track your frequency of use so that we can publish and get more grants to fund this project. And so the login's in the upper right. Once you're logged in, we can then go to the case, hopefully pull it up, and you'll be able to see the contours, all those anatomy, and then again on the right-hand side, as we were showing you within the test case, the pearls, and there's also links to all of these atlases for your further study or review if you have any questions. So with that, I think I will leave you to ask questions, and I think we're ending here a few minutes early. So. Oh, thank you. Jill is just reminding me, on the ACRO page, there is a post-session survey. There's a link there at the bottom of the cases. For those of you, if you were able to contour, if, really anybody wants to kind of give us feedback, we're open to feedback. Tell us what, obviously things didn't work today. Some things did work. Whatever we can learn from this, we continue to develop the site and troubleshoot it to make this experience better. So thank you.